Hey guys, so welcome everyone for this patient-based webinar that Dr. Patterson, the team from Incel DX are presenting today. Just want to say thank you to everyone that's joining us, and also thank you to the advocacy groups, the leaders and the moderators. So I'm just going to start out. We'll have a lot to discuss today with each of the moderators from the different groups. Talking a little bit about themselves and introducing themselves, and then we'll just talk a little bit about our team. So we'll start off with Amy Watson from the Long Hauler COVID Fighters Group. Thank you, Amy, for joining us today. And if you just want to talk a little bit about yourself, be great. Thank you.
Sure. Thank you, Dr. Yo. Yeah, I'm Amy Watson. I'm from Portland, Oregon. I started the Long Haul COVID Fighter Group the end of April last year and thought there might be like a dozen or so of us, but it turns out there are thousands and thousands of long haulers out there. And my eternal claim to fame will be having coined the term long hauler. So that's all I got. That's my contribution to the, to the conversation. But thanks for having me.
Okay, and Karen Bishop. Yep.
Hi, everybody. I'm Karen Bischoff. I am from South Florida. I founded the COVID-19 Long Hauler Advocacy Project last July. Our group is full of long haulers, unfortunately, many now reaching a year post-diagnosis. We are huge on advocacy and patient involvement, fighting for legislation and research. And we're really keen on trying to educate our members. So welcome to everybody who's here tonight.
And next up is Miranda Erlinson, and she's from COVID Survivors from Texas. Hi, Miranda. And I think Miranda's connection just, all right, we'll just move on. Oh, there's Miranda. Okay, hi, Miranda. Yeah, we hear you.
Hi, sorry.
Yeah, Miranda, do you want to just say a little bit about yourself and the group?
Miranda Erlinson, and I founded the Okay, sure. Yeah, so I'm from Austin, Texas, and I'm a middle school teacher, and I'm still teaching. After 10 months, this group, COVID Survivors from Texas, and I just wanted to create awareness, across Texas and how COVID's affecting people as well as our kids. And that's really what I'm here for. So thank you.
Thank you, Miranda. And next is Lisa O'Brien from the Utah COVID-19 Long Hauler Group. Oh, Lisa, you have to unmute yourself.
I'm muted. Okay. Lisa O'Brien. I'm from Utah, obviously. One of the very first long hauler groups that I found was Amy's group, Long Haul COVID Fighters. There were 300 of us at the time. I think I found it at the end of April. And so I got sick back in March. I'm in month 11. I started the Utah group, when I was getting tired of waiting for I just wasn't finding any local resources. So I started the Utah group to try and build awareness here in Utah.
And yeah, thank you, Lisa, for joining us today. And sort of probably one of the big brains behind the operation is Chris Mita from Incel DX. I know a lot of the patients, most of them have interacted with Chris, probably even more than Dr. Patterson and Dr. Parikh and myself. So this is actually probably the first time we're getting Chris out there. So Chris, first of all, thank you for all the hard work and all the support you've given us. So if you want to just sort of introduce yourself, please do.
Sure. Oh, thank you. That's a very nice introduction. Thank you, Dr. Yogendra. My name is Chris Mita. I am Chief Business Officer at Incel DX, and I am responsible for all the logistics of the program. I have spoken to many, many long hauler patients over this last 8, 9, 10 months, however long we've been doing this, and I'm very honored to be part of it. And now I'm also in charge of moving all the program now to our first CLIA clinical lab, which I'll be talking about a little later in the program. So we're very excited about this, and so as I said, very honored to be part of the program. it's been, we really hope we can help.
Thank you, Chris. Yeah, you've just been such a huge backbone of everything we're doing. Next up is one of my friends from medical school. If you live in the New York City area, you know her as a TV. She's a medical correspondent on TV. Dr. Purvi Parikh. She's an immunologist and allergy medicine doctor at NYU, and she's part of our long hauler research team. So, Purvi, thank you again for joining us.
No, thank you. Thanks for having me. And I'm really excited that we're focusing on this. You know, we've been doing a lot of research in COVID in general, that I've been involved with the vaccines, seeing the natural history of it. But I think we really need to study all of these people that are kind of left out of the picture, you know, the non-acute phase. So we know majority of people, even months later, still have symptoms. They say 75% of people, even 8-9 months, a year later. So I think this is very important information that we're collecting.
Yeah, thanks, Purvi. And yeah, you guys know me, Dr. Yogendra. A lot of you guys know me as Dr. Yo. If you haven't known me already, I'm the guy that's sending memes and GIFs on Twitter. But has been helping Dr. Patterson. You know, I will say this: we're past the talking about do long haulers exist or not. We started looking into long haulers, Dr. Patterson and I, back in May. And when I actually told Dr. Patterson about these group of patients, he was already brainstorming ideas on how to research this. So, you know, one of the things you'll realize once you get to know the rest of our team, and especially Dr. Patterson, is he's so far ahead of the curve. It's just incredible. And I'm very grateful having to work with him, Chris, Purvi, and also, and most importantly, interacting with the patients and obviously the advocacy groups here. We're learning so much. It's been a very, very humble process. So that's all I have to say. And now the next up is the person who created the magic bus that all of us wanted to jump on, and this Dr. Patterson. So I will let him kind of do his introduction and really take it from here. So thank you.
Well, thank you, Ram. And I'd like to thank Chris and Purvi and our group putting this all together. It's been an amazing journey for us. And it has been driven, like Ram said, by the people who are suffering from, you know, long COVID and long-term symptoms. When I see the list of symptoms, and some of them are a page long of what people are suffering through, it's gut wrenching, and you know, you just can't stand by and let something like that happen without understanding it. And you know, we're in a satisfying period right now with the you know, COVID long hauler treatment center, because I think we have our arms around it. We don't profess to understand everything, but I think we have a really good basis of knowledge about what's going on. And I think what really started it was that in the spring we would see, or I would see, these patients, you know, at 28 days, and even though they were being discharged and you know, and we're going home, clearly their immunology was not normal. The hallmark at the time, what I talked about in the spring and the summer, was how heterogeneous COVID is. I think it really is. You know, what we wanted to do is do some computer modeling, some machine learning, some AI around these various groups in different stages of the COVID continuum, and see if there was any signatures or any patterns that would give us a clue in terms of what's happening, and whether or not individuals are going to have long-term effects, and what those long-term effects really are, what they're caused by, and how can we effectively treat them in a very rational way, driven by precision medicine. I mean, I went on a precision medicine conference a couple of weeks ago and said, here is the most complicated disease known to man, and we're not using precision medicine, except for us. And that's the conundrum. And over the holidays, helped you know, several patients who were in the ICU recover, and you know, the fact that there was so little information on the patients immunologically, you didn't know where they were in terms of the disease process. So we've tried to rectify that, and we're using that information now extensively to tailor therapies and to monitor improvements and look at most importantly, where are the correlates of improvement? If you're improved, what is it about your profile that says you're improved, so that we can reproducibly say to other long haulers, listen, if we can get to point C, we know you'll improve. And we'll talk about that a lot more during the discussion today, but that's really been our goal is, let's get onto the road to improvement. And, I'm very grateful to everybody who's participated with us. And I really do think I've heard some stories of great improvement, and we want to continue in that vein. And I'm thankful to be here. So appreciate everybody listening.
Thanks, Dr. Patterson. I think we'll kick things off. We're going to dive into the research, into the science, a lot about the different medications, the long hauler index score, and also more importantly, in the discussion, Chris is going to go over the details of the entire project, sort of the nuts and bolts of how the clinical lab's going to work and our concierge model, and how we're going to be able to work with your current physicians and also the network of physicians we are building. This is bigger than just us. This is bigger than Dr. Patterson, me, Purvi, Chris, IncelDX. We need buy-in from the medical community. And in order to do that, we have to have a process in place. And we're going to talk a little bit about that and why, I think there's been some questions about why is it taking this so long? There's just a lot of regulatory things and from a legal, regulatory, FDA, federal, medical licensing things that we have to cross, and we have. And so we're actually very operational right now, and we're going to get better and better as and you can see, we're just a bunch of independent doctors that just came about and wanted to do this. So we're learning on the fly. And I'm also very grateful for everyone's patience and working with us and a lot of the kind messages of support. So we'll get things kicking off. I know, so Karen Bishop from the COVID-19 Long Hauler Advocacy Project will have the first set of questions for Dr. Patterson. So I'm going to get her on the screen and to start the discussion. So here we go.
Everybody has heard about your long hauler index now, and there are tons of questions out in the community. So thank you for meeting with us today to educate the community and let everybody know what is going on. So the first question is, what led you to develop the long hauler index?
That's such a great question, because as I just mentioned, in the spring and early summer, my thoughts were that this is such a heterogeneous disease. I need to get my arms around, how heterogeneous it is, and frankly, I'd like to take credit for the long hauler score, but it really was a computer, and we were just feeding it data, and it basically spit out the long hauler score as it really not only identified long haulers, but created an index that, as we now know, following treatment, as patients get better, it gets lower. I don't know that how high you can go in terms of severity, but the computer has generated a range from 0.75, which is normal, and frankly, patients with active COVID are less than 0.75. So it really makes a distinction between active COVID and long haulers, which was very important to us to say. Long haulers are a very, very distinct group with their own immunopathology. They have a very distinct immune alterations, and that's what the long hauler index has really shown us. And in addition to the long hauler index, the panel that we've chosen after looking at probably close to 1,000 COVID patients across the spectrum of disease, is we chose a panel that had cytokines, chemokines, immune cells, that really cover the gambit of COVID disease, in addition to creating a severity score for patients who have active COVID, and letting us know which patients are going to be severe, and then also generating a long hauler score that distinctly identifies those individuals who are long haulers, and then be able to follow that with therapy has been just a godsend and an incredible tool to take the subjectivity out of it. I know long haulers are suffering. They have tremendous number of symptoms. I think it would be, very difficult to base something based solely on symptoms, because that is truly heterogeneous from patient to patient. So thankfully, we found a signature within all long haulers that allows us to track and manage.
So really to piggyback off of what you said, you talked about the long hauler index basically going into an AI system. One of my questions was, how did you come up with the long hauler index, or the equation for it? And at the same time, it seems that there's a lot of emphasis on the CCL4 as the denominator. Can you talk about how all of that came about and what the significance of it is?
Yeah, I think that's a great question. And I mean, at first glance, if you look at the difference between active COVID and long haulers, it's very clear that some cytokines are very, very different between the two. I mean, I've always talked about RANTES, but RANTES is elevated in mild to moderate, RANTES is elevated in severe, RANTES is elevated in long haulers. It wasn't a differentiating marker. Okay, so one of the big questions I always get is, well, you've talked about RANTES since February. How come you're not talking about RANTES in the context of long haulers? Well, again, I do. I think 50% to 2/3 of long haulers have RANTES elevations, for instance. But it wasn't a differentiator that said you are a long hauler or you have active COVID. And when we did the computer modeling, what really distinguished it was interleukin-2 and interferon gamma levels, and I'll talk about that in a moment, and CCL4, which was lower than in the normal population. And again, that's a marker produced by immune cells that allows immune cells to traffic, and it's similar to CCL3 and CCL5, which of course is RANTES, but it's regulated a little bit differently. So it was really the computer that generated that. But what was so intriguing about the long hauler scores, interleukin-2 and interferon gamma are both type 1 cytokines. Type 1 cytokines are very characteristic of a cell-mediated immune response against pathogens like viral infections. So in many ways, the immune profile of long haulers is much more appropriate and understandable than, say, the immune chaos that you see in active COVID. And that's basically what the computer spit out for us. And, again, and that's what led us to looking for viral persistence, which we published in November, patients out to 90 days with detectable COVID. Now, there's others out to 100 days and more. Whether it's replication competent, we don't know, but there's certainly continuous antigenemia of some type that's causing this elevation in type 1 cytokines that make up the long hauler index.
So when you started the long hauler index, what did you expect to find? What are you finding? And are you seeing any patterns in males versus females, age differences, anything having to do with severity of disease course, any pattern at all?
Yeah, I mean, that's such a great question, Karen, because, I would truly expect there to be the differences in the populations that you suggested. But what we're seeing so far is there really aren't many differences. I mean, I think there's certainly a suggestion that the higher the score, maybe the more severe the symptoms, but but what we do know is that when people are treated and they're feeling better, we see a decrease in the long hauler index. And I think that's what we all want to be able to see. And there's two kind of sub analyses that are taking place that came off of the long hauler score. And that is the relationship between symptoms and a specific cytokine or chemokine, or set of cytokines and chemokines, so-called cytokine specific or symptom specific cytokines, which I mentioned briefly on Twitter, SSC. And then the other thing is we're relating different therapies to lowering or normalizing certain cytokines. Those are the major pieces that are necessary, because then we can go from what drugs are best for what symptoms. And we've already worked it out for one cytokine, and it's a lot of computer analysis. But VEGF, which is elevated in 79% of long haulers, and causes the burning sensation, the neuropathies, so numbness, tingling, weakness, etc. Brain fog is highly correlated with VEGF. And we've taken that in our other modeling one step further, and we know that Miranda decreases VEGF, and by definition, has been improving brain fog. So we want to be able to do that. You know, we had a list in our paper of maybe 20 to 30 long hauler symptoms. I've seen other papers where maybe it's 200 or more, or maybe some variations on a theme. But at the end of the day, what we want to be able to say is, okay, you have these symptoms. I think we need to treat you with X, Y, and Z. And I think we're almost there. And I'll say treatment has really revolved around combinations of therapy. So our triad of great therapies so far has been Ivermectin, Miranda, which is a CCR5 inhibitor, and low-dose steroids for at least 2 weeks with seeing improvement. And you know, the great thing with Ivermectin is it's been proposed as an antiviral, as an immune modulator. We do think if there's persistent viral presence somewhere, and maybe even low levels of replication, that's doing some good work. And of course, there's the patients who don't respond to it. We're expecting that. But I would say 85% to maybe 90% are responding to any of these combinations with ivermectin. And of course, the Miranda brings RANTES down, brings interleukin-6 down, just like we saw with leronlimab, and also brings VEGF and TNF-alpha down. So again, we can sort of pick the alterations in the entire 14-plex panel and say, okay, how does that steer us towards a particular therapy? So it's been very, very effective, and we're not just flipping a coin or throwing something against the wall and hoping it sticks.
So there were a lot of questions that came in about CD8. Can you talk about the significance of CD8, and are you seeing those with a low CD8 have a higher long hauler index?
Great question. The CD8 count was something we found probably in as early as February, that the most severe critical active COVID patients were supremely immunosuppressed with very low CD8 percentages, you know, in the single digits, 2 or 5 or 7, when normal should be 30% or more. And it was analogous to AIDS, where, you know, HIV AIDS, you had low CD8 and low CD8 percentage, CD4s and low CD4 percentages. But it was the other, you need both of them, 4s and 8s, to elicit a strong, you know, a response against viral infections or a strong response against cancer. And, you know, these patients, these COVID patients, were just as immunosuppressed because of low CD8 percentages. And in fact, you know, we found a patient early on who had a life-threatening life-threatening cytomegalovirus infection because of they were essentially immunosuppressed and immunocompromised. So, and then when we continued to monitor CD8%, again, we published a paper with Phil Mudd and at WashU in St. Louis in November that showed an individual with a low CD8% had detectable virus out to 87 days. And that's when we started looking at long haulers. And sure enough, even though the average long hauler CD8% is normal, what we were finding is that 25% of long haulers had low CD8 percentages still 8 months, 9 months, 10 months after infection, which is incredible. And so we're just now trying to put that together with, like you said, with long hauler index or specific cytokine abnormalities to see exactly what the implications are of that. Hot off the presses today, we've also been doing Delta 32 genotyping for CCR5. As you know, CCR5, Rantes binds to CCR5. That's basically I used to call it the quarterback of the immune system, and allows cells to traffic to regions of inflammation in response to elevated Rantes. And, the levels of CCR5 are very important in terms of, having a CCR5 antagonist like Maraviroc and leronlimab be active against those cells and temper the overwhelming immune response in active COVID. Well, there is also some thought that maybe a Delta 32 deletion, which actually those individuals make about half the CCR5 receptors that normal individuals with both CCR5 genes do. And indeed, they think that the Delta 32 deletion is protective against severe COVID. And in fact, today, we just finished our first wave of analysis of over 100 patients across the COVID spectrum. And the results are in, and 20% of mild to moderates have the Delta 32 allele, which is common in Northern Europeans and elsewhere around the world. 25% of long haulers have the Delta 32 allele, and 4% of severe to critical COVID patients have the Delta 32 allele. So indeed, it does seem to have a protective effect against severe disease, but may also have ramifications in terms of cellular migration and therapy in both the mild to moderate group and ultimately in long haulers, and maybe lower doses of Maraviroc or leronlimab should be considered in long haulers with Delta 32 because there's less receptors to block. So this is some of the key findings that we've seen so far at the genetic level.
And just to clarify on that, for some people who may not be familiar, you're basically saying those that are heterozygous, right?
Correct.
Okay. So heterozygous means you have one.
You have one of each.
Right.
You have one deleted and one quote wild type or normal allele. And what the manifestations of that are that the immune cells that express CCR5 have less CCR5 on their surface. So they may not as vigorously respond to high Rantes as those with double wild types, which is maybe why the severes get such a raging cytokine storm.
I saw your post on Twitter and you made me run my raw DNA and I found that I was in that heterozygous bunch.
Good for you, as am I.
So the last question for this section has to do with long hauler children. So we know that long haulers themselves have kind of been on the back burner, and there has not been a lot of talk about long hauler children. Some were wondering, does this long hauler index and its current algorithm, if you will, apply to children, and how would treatment for children differ?
Yeah, I think children above the age of like 2 or 3 who have a relatively competent immune system, there shouldn't be much difference in terms of long hauler indices. And we could look at the pediatric population in particular, but if they're 12 to 12 years old or 8 to 16, I wouldn't suspect there'd be much of a difference. I mean, the thing that concerned me with active COVID was this finding of a Kawasaki's like disease with the cardiac manifestations, which ironically are driven by Rantes in Kawasaki's disease. And very interesting that after we identified Rantes as being significantly elevated in active COVID, that all of a sudden these kids were developing a Kawasaki's like syndrome, which again would be amenable to CCR5 antagonism by the drugs that I've mentioned. But it would certainly be a group to look at in terms of outcomes when we really get rolling.
And would the treatment drugs like ivermectin and maraviroc or leronlimab, would those all be safe for children?
Yeah, for the most part. And again, maybe with children, but we want to do this anyway. Children certainly avoid high dose steroids because of the side effects and potential for growth. But again, I think we have enough in our armamentarium to be able to treat those individuals as well.
Perfect. Thank you so much.
Thank you.
I'm going to hand it off to Miss Amy Watson.
Well, here we are. Okay. Dr. Patterson, when we talk about neurotropic viruses, those that cross the blood-brain barrier, those viruses are capable of going dormant and reactivating later. So had the chicken pox, don't want to have it again. Do you think that this is responsible for post-COVID syndrome? Is that what we're doing?
It's a great question. One of the questions that I initially was thinking about when I saw this immune profile in long haulers, which was really indicative of a reactivation or a superimposed viral infection because of the dominance of the type 1 cytokines. And we looked at CMV in some severe patients, and there wasn't even reactivation of CMV in severe patients. We found some evidence in long haulers that some long haulers have elevated B cells, which might be indicative of Epstein-Barr. And so we've kind of put those off to the side, and when we get the opportunity, we'll look for Epstein-Barr and Epstein-Barr reactivation. It wouldn't be surprising, given how prevalent, and these are herpes family viruses that have true latency. So unlike RNA viruses that usually come and go, but maybe they stay around, and like COVID I started looking at autoimmune diseases in the mid to late 80s, and with a virus called Coxsackie B, which was a RNA virus. But basically they would come, they'd do their damage, and then they'd get cleared, and then you'd be left with the immunologic manifestations, kind of like long haulers. So this pattern isn't surprising of a post-viral syndrome that could be caused by anything for that matter. But whether or not it's Epstein-Barr, herpes simplex, HHV6, cytomegalovirus, all of those are possibilities, and everybody's going to be different. Varicella is another one, so chickenpox or shingles. So they're all possibilities. The immunology looks like what you would see, but to me there'd be other manifestations. I mean, if you had an outbreak of varicella, you would see lesions of shingles. You would see Epstein-Barr. You would see probably swollen lymph nodes and maybe even a swollen spleen, and you'd be, exhausted and chronic fatigue, and also cytomegalovirus is also another chronic fatigue virus. So yeah, if I was a betting person, I would say that there are some long haulers that are just having reactivation of their latent herpes virus family type viruses, which include many of the ones that you've discussed.
Right.
And in terms of being neurotropic, I mean, there's a difference between kind of being neurotropic and actually, getting through to the brain. And the good news is we know Maraviroc gets into the brain. There was a paper from 2014. I think there's discussion that leronlimab gets into the brain as well. So I think we're able to get the drugs that we need to get into where we may have viral reservoirs. So and ongoing inflammation.
I sure hope so. What about viral particles hiding out, viral persistence? You mentioned Th1 immune pathways. Yeah.
It's weird. And I think someone brought up, I don't know if it was you. Yeah, it was you, Amy. Sort of the similarities between COVID-19 and HIV, not in terms of the virus or the pathogenesis, but how we think about them. And I was starting HIV research probably in the late 80s, early 90s, where they couldn't find the virus, and so they were having trouble putting together cause and effect in terms of the virus. We know this virus infects T cells. They found that in the early to mid 80s, but then trying to say, does this virus is it responsible for this massive immune destruction? I mean, I remember a conference in I think it was 1992 where we presented data where we found HIV in CD4 T cells in peripheral blood. And then there was obviously the publication on finding HIV in plasma. But, we asked the same questions. Where's the virus? And, now we know, HIV can be just about anywhere. I mean, I published a bunch of papers with the group at University of Pittsburgh on, virus in semen, virus in seminal mononuclear cells, gut, obviously gut. Gut has 98% of your immune cells, so I wouldn't be surprised if, in the gut mucosa, there wasn't hidden virus. So, just because we can't find it by conventional techniques doesn't mean it's not there, and I think that's sort of the premise that we're going on. As I've mentioned on other talks, we have found it in a long-lived monocyte macrophage population, the CD14, CD16 monocytes, which also harbored HIV, which also harbored hepatitis C. So, that's the premise we're going on right now. And I think a couple things can happen that, with time, either it's not replication competent, or over time it gets eliminated, or over time we tolerize to the antigens that it presents, and maybe we get better, but we don't want to wait, years to say, well, the long haulers will eventually get better. I mean, we have an opportunity right now to treat successfully. So let's do it. But that's not to say that if you left this alone for 3 years, you get better, but who wants to do that,
No, thanks. Yeah. Definitely. Whatever your thoughts on viral evolution in vivo?
Well, that's another great question, especially in line with all the sequence variants that people are talking about right now, and again, very similar to what we were faced with HIV. The big difference is with HIV HIV has a tremendous mutation rate. So it was doing a lot of mutation. There was a lot of different viral sequences, even within the same individual. I mean, within 18 months, some of the sequencing studies we did and others, it had less than 50% homology to the original infecting strain. And so there is indeed viral evolution. And viral evolution really depends on selection pressures, either immunologic selection pressures, in the host, or by drug. So, within the same individual, is there mutation? Yes, but so far there may not be a selective advantage for any of those mutants because there's not great antivirals out right now, and there's certainly not comprehensive antivirals out. And, the immune response, we don't know how great that is in terms of protection, either neutralizing antibody or cell mediated. So it all depends on the amount of selection pressures in an individual. But, we know that there's variation. We know that there may be immune escape variation coming around the corner. So we just have to prepare for it.
As someone who's had a chronic fever for 342 days, I really don't want to be the hostess with the mostest. So I'm really hoping that's not what's going on here. But one last question for you from me. Long COVID is being compared to EBV, Ebola, and HIV. And can you speak to those similarities and differences?
Yeah, as I mentioned, some of the similarities, I think, are in terms of kind of viral host interactions and what it does. I mean, like I said, instead of dropping the CD4% or CD4 count like HIV does, it drops the CD8% or CD8 counts. And, unlike Epstein-Barr, which infects B cells and causes B cell proliferation, so that's another side of the coin. But, again, what you're seeing is a viral infection like the others that you just mentioned that intimately involve the immune system on an ongoing basis. And so you're getting the immune manifestations of that viral infection, and in many ways that's what we have to treat. And ultimately we have to eliminate the virus and possibly even think about during active COVID, are we creating viral reservoirs that lead to long hauling? And we don't know that yet. But I think that's really something that needs to be studied. Somebody leaves the hospital day 28 and most of their parameters are down, but they're never normal. I mean, multiple trials we've looked at day 28 or even later. It's not like your cytokines are back to normal. I mean, IL-6 is usually still elevated, and IL-8 and TNF alpha. I mean, you're feeling better and you're alive, but by no means even at day 28 are you, quote, normal. So
ironically, day 28 is when I first tested positive for COVID. So I was a little perplexed by the CDC recommendations at that time.
And you know what? I spent my life. I'm trained in laboratory medicine, and I've spent my life interpreting test results, first at Northwestern, then at Stanford. And the fact is, we used to struggle with the same issues during seasonal virus seasons when I was running the clinical virology labs. You would have tests that, everyone, here's the conundrum. Everybody wants a fast test, almost like a pregnancy test. I used to call those the 80-80s. They had 80% sensitivity and 80% specificity, and they put you in no man's land because you had both false positives and false negatives. That's where we are now. And then, of course, everyone wanted that rapid PCR that could be done in 15 minutes. Well, the only way you can do that is shorten the cycling time, which may not be as sensitive as doing 40 cycles. It takes, 2 or 3 hours. So what we're experiencing in COVID, in the COVID pandemic, is a real lesson in laboratory medicine. And that is, we're dealing with tests that are less than perfect. So how do we adjudicate a positive test or a negative test? And the best answer is, how do you, with adjudication, is you got to just keep repeating it. And of course, that's a resource issue and obviously a logistics issue. And so it's been horrible. And then, of course, the serology tests, were you exposed? Were you not exposed? The performance of those, especially initially, were really, really poor. So you never really knew where you stood. And frankly, I've gotten a lot of questions that, well, does the long hauler index mean that you actually had COVID? Because I never had a COVID test, or my COVID serology is negative. And one of the big things we hear from long haulers is that, they don't have any antibodies, and that may be as high as 30%. And I'm sure we'll get into that when we talk about, should I vaccinate, should I not vaccinate? But 30% or more may not have COVID antibodies. And then they may not have had a great COVID test. So here they are with no evidence of COVID infection, yet they're suffering almost identically to other long haulers, and they register on the long hauler index. So for me, that's even additional justification, and that would be an incredible study too, is to say, here's this group who we know have COVID, here's a group that is COVID PCR positive but serology negative, here's double negatives, here's positive and positive, and see how they register in the long hauler index or the severity score, and say, well, this is confirmation that the original COVID test was a false positive or a false negative. So we're getting there. There's a lot to do.
We've come a long way, but yeah, we're still going there. I'm going to pass off to Lisa. Thank you so much.
Thank you, Amy.
Amy, what I'm going to do right now, Bruce, is I'm actually just going to bring Chris on, because you've been talking for the last 45 minutes. Just get you a little breather there. I'm just going to get Chris on just to talk a little bit about there's a lot of questions about the testing and how people can get enrolled and registered. So I'm just going to bring Chris onto the stream, and I'm just going to take Dr. Patterson out. Chris, so if for all of you who don't know, this is Chris Mehta from IncelDX. Hello. She's the Chief Business Officer, and like I said earlier, the brains behind the project too, along with Dr. Patterson. We have a couple of updates that we're going to talk about the lab and the process. So I'm going to pull up the website. The website is www.covidlonghaulers.com. And I'm just going to pull this up for Chris.
Great, thank you.
And before I kind of talk about that, I'm actually also going to share something with you guys about, maybe I'll do it at the end. The website is getting completely redesigned. I'll let Chris talk about it and show you guys a little sneak peek. Actually, one of the long haulers has been so kind to help us out. We are getting literally better every single day. We're refining the process and streamlining this. And I know, we didn't have a website up for the longest time, and then we've been talking about these labs, and Chris is really going to talk about, the regulatory things, and we have to do this properly. So Chris, just sort of going to turn it over to you. Thank you.
Yes, thank you, Dr. Yo. I just wanted to say hello to everybody and thank everybody for the feedback. I have to say that our website wouldn't be where it is at this point if we hadn't gotten great feedback from all the long haulers. And then we've had, as Dr. Yogendra just mentioned, we've had several long haulers who just did an awesome job in helping us. And we have did Kate Porter, and some of you probably know Kate, and who helped us get started on this and really helped us figure out the essence of it, and gave us the covidlonghaulers.com. It was an awesome, I just have to give a shout out to Kate. And then Harry Garabedian, I think I've kind of butchered his name, but he's doing a web design behind the scenes in parallel right now, which will go live in about 3 weeks. We're very excited. So this is the website we have up now. And if you went to the www.covidlonghaulers.com, this is what you would see. And we've tried to make it very simple and straightforward, but also a resource for those of you that may have questions. So if you want to know more, you can hit the resource button there in the middle, and the papers will come up. And this is kind of a living document that we're continuing to add to. And as Dr. Patterson was speaking about earlier about the different studies that we have going on, he mentioned a couple. Some of those papers are up there. We're continuing to add to it. And as a patient, you would go in, and the big area here is, if you notice, it says register. And this is where we want you to register. And that will actually kick everything off. So I'm going to start there because this is the one probably that's most important to many of you. You register, you give your name, your email, your phone number, your address, and we ask you to split out city and state. Now, this is all very important to us because once you do that, that information will then go on to a CLIA clinical lab that we just started. They got trained and everything. The assay got validated over the last couple of weeks. We've been working very hard. This is not easy to do. These are regulated labs. We have to be super, super careful. We have to adhere to all HIPAA regulations and PHI regulations. And so one of the reasons that we've been a little bit, it's taken a while for us to do these things. We need to do these all so that we are in adherence to protecting your privacy. This is really, really key. Big part of what InCellDX has been very protective of. So I just want to underscore that a couple of times to say that that's kind of what has taken us a while to do. However, now we've got that all done. We transfer your information through a HIPAA compliant vehicle to the lab, and then the lab will reach out to you. They will have your email, they'll have your phone number, and so they will go ahead and reach out to you. That's right. Thank you, Dr. Yogendra's pointing there. That goes to the lab. They will then call you or email you, and you'll have a dialogue with them. You can ask them all the questions you need to ask them. You can talk, they'll give you an overview of the process. Then they'll talk about, where you can get your blood drawn. They will help you find a blood drawn location somewhere near you. You don't have to travel hours away to get your blood drawn. And they will also interact, you'll be interacting with your PCP as well, your patient, I should say that's your local doctor. And so when that happens, then they will then get your blood drawn. You will get your blood drawn. You then send it. They will tell you how to send it back to them within literally 24 hours. They then test your samples, and then that data will go up into a secure portal that only you will have access to, only you. And then you have choices to make. Two choices. One is you say, click, yes, I want my data to go to my PCP. So that data will be faxed to your PCP once you give permission to that. Second click is if you want to have a consultation with Drs. Patterson and the consortium of physicians that are now being put together for the COVID treatment center. And that group of physicians will interface with you and your PCP. They will be a guide to helping with respect to treatment and so on. So I just want to be clear that all of this is done in a very private, and your privacy is protected. Once that happens, then Dr. Patterson and his team will work with your PCP and put you on a treatment plan. So in essence, that is what happens. It's not all that complicated. There are some key points. I'll just review. You register first. Can't do anything till you do. Then the lab will come and they will connect with you, and you can ask all your questions, reimbursement, which they'll give you the diagnostic codes to go and get your reimbursed. You can talk about costs. They will give you all that information. Then from there, they will tell you where to get your blood drawn. Once you get your blood drawn, you then make sure either the location where you have your blood drawn, or you will send it back to the lab. The lab will run your test. Then once they run the test, they will have the data, and that data will go to a private portal so that you're the only one that has access to it. It's a secure portal. Then you have, as I said, two decisions to make. One, you want that data faxed to your PCP, your private doctor. And two, you want to have a consult with Dr. Patterson and his team, Dr. Yogendra and Dr. Parikh, and other physicians as well, who will guide you and your PCP as to treatments. And that's pretty much the program. So hopefully I've answered that. Any questions that might have come up? Have I missed anything?
Yeah, Chris. So the question, some of the questions that I'm seeing is, I know that the labs are going to start, or maybe have already started contacting patients, but just because of how comprehensive, there were over 2,000 patients that registered. It's probably going. Not everyone is going to be contacted this week. It'll trickle into next week.
Right. Yeah. Thank you. Yes, I would say that the lab is starting to actually reach out to patients today. And as Dr. Yogendra just mentioned, we have over 2,000 patients that have registered, which is awesome. And it will take us a week. It'll probably take the lab about a week to get there, but they're already on it. And they will be sending out an e-blast on that whole process so that you know exactly what's going to happen. So that is happening as we speak. And let's see, what else was on the list? I think blood draw. A lot of people had questions about blood draws, but I think I answered that. You won't have to go very far to get the blood drawn. And the lab knows where to get your blood drawn in your locale, so they'll help you with that.
And the other question is about I know you briefly touched upon it, but about the insurance and sort of a little bit about, if you can just sort of comment on that,
Yes.
Chris.
Right. Yeah. Thank you. So your insurance, what will happen is the lab will give you what we call the CPT code. I'm sure many of you are familiar with these codes since you've been doing a lot of your own, having a lot of tests done. CPT codes so that you can submit the diagnostic code and the CPT code to your insurance to get reimbursed. And these are codes that have been around for a long time. So it's not like we have some new code that we're using. We're not. These are codes that already exist.
Yeah, our understanding is that depending on your insurance and the insurance plan, you're using pre-existing CPT codes.
Absolutely, pre-existing. That's correct.
Okay. Now the other question is, the other comment I want to make, and actually I'm going to bring Dr. Patterson into this a little bit. Because this sort of ties into some of the questions we've been getting. And I'm going to get the rest of the Lisa and Miranda back on in a few moments for that questions. But, and this is also a question for Dr. Patterson we've been getting, is about the test assays. And the question is, there's some patients that have gone to Quest and LabCorp and maybe got an interleukin 6 level or a TNF alpha. And then we've tested them and they're obviously seen some elevation. The question is more, how did the InCellKine assays compare in terms of some of the sort of the things that Quest and LabCorp are using? Because I guess some patients are saying that they're getting their lab results at Quest and they're having zero, nothing is showing up, none of their cytokines are elevated, and their doctors are going, well, okay, but if we're showing that they have elevation, how do we account for that discrepancy?
Well, I think it's a couple of things. I mean, number one, you can't, any assay that's quantitative, it could be, PSA for prostate or, ERPR for breast or anything. They have to be sent to the same lab. It's very difficult because every lab has their different normal range to do interlab comparisons. Number two, I think we developed the most sensitive assays known to man. So I think, that's the other reason. The third reason is cytokines and chemokines aren't standard. And I know for some of these big labs, they get sent to one lab and then they get sent to another lab. All of that is time, and time is not on the side of an accurate result. So that worries me. The good news here is it's from blood draw. It's literally from your arm to the lab, and there's no, shuffling. There's no receiving. And trust me, I've been in the clinical laboratories at 10 o'clock at night or midnight, and back in the PCR days when you're like, that sample can't be sitting out there, and you just don't know. And cytokines are very labile, and it's not something you want sitting around because time is not on your side with cytokine analysis. And that's why we've set up the system that we set up. Plus, it's very odd that people have these enormous symptoms that are very indicative of immunologic abnormalities, yet they have nothing. That's shocking to me. And I think that's what we really identified, is that there's discrete patterns. We have the advantage of having machine learning and AI on our side to say, yeah, you truly are a long hauler, or you're an active COVID, or you're a normal. I mean, that's the benefit of doing, the testing through us. And again, after therapy and you want to do repeat testing, you cannot send it to another lab, because they need to be able to do the same test in the same way and get it reported out with the same normal range and the same controls. So, but that's the elegance of what we've really set up with our partner labs, and why we think, this is a program that's solely focused on long haulers, and that's our mission. And we don't have 10,000 other tests that we have to run for different conditions, and it's our business.
Dr. Patterson, Amy was asking if we could comment on the legal responsibility of our PCPs for their PCPs to act on the results of our assay. Could you comment on that?
Yeah, I think, again, everybody that we've tested so far, we've done under research conditions. And I can completely understand a PCP saying, well, I don't think we can order this test because it's for a research study, or it's for this, or it's for that. I think the fact that this test has been validated at multiple labs, and we'll be able to do it under clear regulations and under regulatory type will make PCPs much less resistant to sending labs off to a research lab like InCellDX. So I think that's going to make all the difference in the world. And again, I think that's the importance of us continuing to publish and sharing the data that we have on long haulers and the treatment successes that we have, so that the PCPs have really nothing to challenge, unless they have some other bright idea on how to deal with this. But I think what we've done is we've removed sort of the research use only stamp from all of this, and now it's at legitimate clinical laboratories.
And Chris,
I did want to say, Dr. Yogendra, one more thing about the labs. We've set up one lab already, and I just want to be sure that we are getting ready to send up another lab as well. So there'll be at least 2 or 3 labs within the United States. This isn't going to be an assay that we run at every lab. That's not going to happen that way. As Dr. Patterson said, we need labs who really understand the program, understand this is a partnership, and understand what the whole program is about, and embrace each lab that we're setting up understands that and embraces it in the way that we've embraced it, because each one of these labs is a CLIA certified lab, and they're an extension often of InCellDX, in the sense that they are carrying our mission forward, and that's very, very important to us. So we aren't going to just offer this everywhere. It's going to be very discrete labs.
And
yeah, so I'll second what Chris said. We're not going to be part of somebody's test menu. And then the other great thing is the one of the labs that Chris just mentioned is all over Europe. So I get a lot of questions on how quickly can we get this going in Europe. And the fact is, we will be going in Europe. We're going to get live here first, and then we're going to focus on getting live in Europe and implementing the program over there and signing up other network physicians that can help out. I mean, we're getting great response from physicians around the country. Dr. Galis, who's doing a big trial in leronlimab, he called us. He wants to be able to do the type of testing that we're doing for his patients, and we're very excited about that. And like I said, we've probably got 3 or 4 other clinics that have called us and want to participate. So the precision medicine based approach to long haulers and their treatment is something that we're very excited to take the leadership role, and also very excited to collaborate with those who want to also help with this horrible condition.
Thanks, Dr. Patterson, and thanks, Chris. Yeah, I think you've sort of answered some of those major questions regarding all of the sort of the process. I'm going to add. I think Lisa had some questions now for Dr. Patterson, and I will also, we'll come back to this question about the network of the doctors. Now, one of the big things that I think a lot of the patients have expressed to us is the lack of buy-in from their doctors. And I think Dr. Patterson and we can probably attest to the fact of some of the rude emails and having the phone hung up on us as if we're sort of peddling some quack science, or we're not even physicians ourselves. So we understand there is a lot of skepticism and there's a lot of resistance. But I think Dr. Patterson probably talked about his experience during the HIV era. It's just keep on chipping away as long as we have the science and research, and we're continuing to collect data and have a system and a scientific way of approaching. We know we're going to start to get the buy-in. And if you guys are following me on social media, I've been connecting a lot of you guys with different doctors all over the country, doctors in California, Oregon, state of Washington. I just talked to a doctor this morning in Florida, so I think we might have another medical practice in Florida that can see patients there. So I know Chris and Dr. Patterson are also hearing from physicians and building this network up. So I just want to just recap this thing. As you guys can see right now, it's been a really long journey, and there's so many different moving pieces. I know Chris just talked about the sort of the patient side, but if you look on the other side of that graph, there's the physician side, and we're kind of, the lab, we're building the lab part, we're building the portals for the patients. And at the same time, we're building the network of physicians. And I said earlier, this is bigger than any individual person here. We need the buy-in from other doctors. We need the buy-in from the medical community, and we're doing that. So again, thank you everyone for your patience the last couple of weeks and months. We know how frustrating it is. We want you guys being tested now. We want to talk to your doctors and get you on therapy. So but I know there's a lot more to discuss. So thank you, Chris, and I'm going to leave Dr. Patterson on. I'm just going to pull up Lisa O'Brien from Utah.
Hi, Dr. Patterson.
Hi, Lisa.
So my first question has to do with the different diagnoses that we're seeing in long haulers. I think it was probably back in May when Mount Sinai first started talking about dysautonomia. And since then, we're starting to see a lot of people get diagnosed with dysautonomia, and more specifically, things like POTS, chronic fatigue syndrome. We're seeing a lot of autoimmune diseases like lupus, Sjogren's, rheumatoid arthritis, vasculitis, small fiber neuropathies, mast cell activation syndrome, and I could go on and on. So my question is, do you believe that maraviroc and leronlimab can reverse some of these conditions in those of us that have already been diagnosed? Or do you think these medications are more aimed towards people that have not been diagnosed? And if you do believe that these medications can reverse this disease course for those that have already been diagnosed, do you think that's going to be true for like the entire population of people that have been diagnosed with these types of syndromes way before COVID came along?
I mean, that's just such a great question, and I think you know, a lot of it has to do with, you know, what was the initial damage by the virus. You know, it infected endothelial cells, were there microemboli, et cetera, et cetera. We know obviously that you know that I think there is a vasculitis because VEGF and soluble CD40 ligand, for instance, are still elevated. So, and these are all general. They can affect just about anything. When you're starting to talk about autoimmunity and autoimmune disease and that kind of thing, you know, when you have hyperimmunity, my concern is when you do assays on somebody who has hyperimmunity, there's a lot of false positives, and that's coming from a pathologist, laboratory medicine trained person like myself. I have a lot of difficulty in somebody who's got huge amounts of generalized inflammation, running assays where you're looking for, you know, antibody binding and trying to decide whether it's specific or not. And I think that's a hallmark of some false positives. So I think there's an element of that. There's also an element of, you know, if I'm hyperimmune, am I going to have autoreactive antibodies? Sure, I'm sure that's a possibility. Now, you know, the key is, though, you know, T regulatory cells are actually been proposed as a therapy for autoimmune diseases. My fear with CCR5 antagonists is like Miranda and leronlimab, is that in autoimmunity, you might be inhibiting the T regulatory cells that are there to shut off the immune response so you don't get autoimmunity. So Miranda and leronlimab are great in, you know, hyperimmunity and immune dysregulation, as we saw in active COVID. The one area that I've always been concerned with CCR5 antagonists has been in autoimmunity, and that's sort of the domain of the immunosuppressives, the steroids, the rituximabs, even the Humiras, you know, inhibiting TNF alpha. Those all come into play kind of in this, you know, this autoimmune landscape. And again, I think steroids have been helpful. I think the one thing that hasn't been helpful for long haulers are these steroid dose packs where you start at really high levels of steroids and then you taper down. I think that's just wrong. Number one, because high doses of steroids just make you feel so poorly, and they have their share of side effects. And then I had a great mentor at Northwestern named Roy Patterson, no relation, who published over 800 papers in allergy and immunology and wrote the book on it. And he had every asthmatic patient on 5 to 10 milligrams of prednisone with great success. And that's what we're proposing here. Is it doesn't take a lot of steroids. It just takes a consistent low level. Add in some ivermectin, add in some Miranda, and that's where we're seeing the success. So yes, I'm concerned about tossing CCR5 antagonists at autoreactive conditions, autoimmune diseases, people with autoantibodies. I think that's still in the domain of some immunosuppressives.
You brought up, talked a little bit about the persistent inflammation. That kind of seems to be like, is that the main culprit for this, or is there something else at play?
Well, no, we see that in the panel that we run in the long hauler index. It's, I think, in our paper, I can't remember offhand, but maybe 8 of the 14 markers were maybe less than that, maybe half of the markers were elevated beyond the 95th percent confidence interval, and it's still hyperimmunity. It's a more characteristic hyperimmunity than the chaotic immunity in active COVID. But yeah, it's clear that your body is still reacting against something. So I think the big key is, what is the something? Is it still bits and pieces of virus? Is it, viral protein that lingers? Is it the virus itself? Still trying to figure that out. And the fact is that we've done a few Lyme patients, we've done a few fibromyalgia patients, and they actually register in the long hauler index, which I find very interesting, because I think we may be onto something with a patterned immune profile that may exist in many post-infectious conditions, and maybe we can help those individuals out as well while we're really helping the huge numbers of long haulers. So yes, I think this is something that may transcend the long haulers, at least in terms of the approach, and I think we can find strategies that may work for a lot of these conditions. I'm just leery of. I started in autoimmunity, so I'm a little bit leery about using immune modulators in autoimmunity.
Yeah, I think that's really cool. I think that a lot of us are kind of hopeful that some of these studies that we're seeing being done will help others that have had these post-viral syndromes. My next question is, we've seen some long haulers ask for the acetylcholine receptor ganglionic antibody test, which is only marker for dysautonomia or autoimmune dysautonomia. And we're seeing some of these tests come back positive. Is this something that you guys have considered adding to your long hauler index?
Again, I think if we think about long haulers maybe being as high as 30% of all individuals who had COVID, I'm sure there's going to be individuals who have some abnormalities that don't fall into the patterns that we're seeing, and that may be one of them. Or again, it could be just a manifestation of huge amounts of inflammation and the assay being a false positive. I mean, there's no perfect assay, and so I worry about things like that. And my recommendation would be, if you got something like that, I would demand a repeat. So, and again, a lot of the dysautonomia we found associated. Again, that's why we're doing this study of relating symptoms with specific cytokine or chemokine abnormalities, and we're seeing, VEGF being highly elevated in those individuals with these dysautonomias and with peripheral neuropathies and things like that. And the cool thing is, and I'm going to announce it now for the first time, is just this morning we laid out an app. We're developing an app, and we have a watch that is far less expensive than standard watches on the market, that would be able to run the app, where you could record symptoms and score them for yourselves, but it would be overlaid with blood pressure, heart rate, and heart rate variability, or HRV, which Dr. Yo can talk about more. But we want to be able to have something that tracks symptoms, tracks lab values, and tracks treatment, to really see on an individual by individual basis, this is what we're all about here. What's helping, what's not helping, and what are the correlates of improvement in terms of lab values. And I think the two studies that we're doing relating relating symptoms to immunologic abnormalities, and then immunologic abnormality improvement to treatment. Layer on top of that an app that allows the patients to know and record how they're feeling in response to something on a real-time basis. And then as a COVID long hauler treatment center, be able to access that information and guide treatment decisions is going to be invaluable. Because I think you're absolutely right. I think there's probably some things we haven't even begun to think about in some individuals that are unusual. I mean, one person we learned had adrenal insufficiency. So we don't claim to know what people have in terms of underlying diseases all the time, but we know that they're suffering. And so, we don't rule anything out. It's possible, but we're starting to see at least patterns that fit a lot of what we're seeing.
That's really cool. Any idea when you plan on having that app up and running?
Yeah, so I just had a meeting on it this morning. I think it's going to be probably 2 to 3 months, but we're really excited about it because it'll that time period. We have the design and kind of the architecture. What it'll allow us to do is see how things develop over the next 2 to 3 months in terms of treatments and diagnostics, and make sure that when we come out with the first generation, and of course we'll also get input from you, all the long haulers and the long hauler groups to say, this is something else I'd like to see in the app. But to be able to overlay, blood pressure, heart rate, HRV, heart rate variability, with lab values and with patients' own assessment of their symptoms, just would give us an incredible amount of data with which to tailor our therapies.
Awesome. That sounds like it's going to be really valuable for a lot of us. Mm-hmm. All right, I'm going to turn it back over to Amy now.
Hi, Dr. Patterson. Thanks for having me.
Hello.
Hi, I'm Miranda Erlinson. I'm from COVID Survivors from Texas, and I want to talk to you about a couple of questions. First of all, long haulers, we need our own legislation, national legislation that, that can protect our job, medical benefits, other benefits while we're unable to work, as well as coverage for all of our health issues, to have them completely covered, as well as being able to work with a network of providers that are ready and willing to just dive in with these long hauler issues. Has there ever been a public health crisis in which something like that has existed for a marginalized group like this?
Well, again, I'll harken back to my HIV, background and say that, that happened then. And there was a lot of stigmatism as, in a different way. I think the long haulers are feeling, this is psychosomatic or this is that. And I think we've put that to rest with identifying that there is definitely something going on. In fact, there is something incredible going on. And, so I think we put that to rest, and we're trying to talk as much as we can. I'm talking to a payers group and talking about insurance, but, we've been so busy putting this all together. The one thing that we could really use the help of all the long hauler groups is with PR. I mean, and with getting some messaging out there, because, I'm willing to talk to anybody, and I'll stake my career on the fact that this is something that's very, very real. and I will go and talk to anybody known to man. I mean, it doesn't matter. But what does matter is getting, the payers and insurers and groups to realize that there is no doubt that this is a distinct manifestation of COVID infection and has to be treated, from a disability standpoint and an employment standpoint as such. And happy to do it. We just, like I said, we've been so busy. We haven't hired a PR firm, but like I said, you get us in front of somebody and we'll talk, and we won't stop talking. So I can guarantee you that.
Okay, thank you. So what do you think we could get the current the current administration team to do in regards to safeguarding those benefits for long haulers? Do you think that's possible?
I think it's possible. We ever since February, I've talked to, BARDA and OWS and a number of different people in the government. And, listen, I mean, there's some people I can call, and I can certainly make my voice heard in the new administration. And again, completely willing to do that. And, just about anybody who gives me a name, I'm happy to pick up the phone and call them. And we have talked to some very important people. It's just, we didn't have the data that we have right now. We have a database of information that will really, really make this case. And, I'm writing like crazy, both lay articles and obviously publications, and, willing to talk to anybody and everybody about this condition and what it's doing to individuals who are completely debilitated. And it's not right that they aren't getting the protections that they need.
Well, thank you. Speaking as someone who's completely debilitated, my next question was going to be to ask you what your company can do to help us to speak to people and get the understanding of those disability benefits and medical coverages. But you answered that. You said you'll talk to them. So I guess I'll just have to get, the president's cell phone number or something.
Well, listen, I mean, it's not that we're,
so
we're talking to the people that we have access to. I would love for someone to give us some people that we don't have access to. I mean, we'll work our way up the flagpole if need be. But like I said, if somebody has a phone number, I'll pick it up.
Okay. So I have another question right after Miss Amy. I'm not sure if Amy's coming on, but I do have another question.
Go ahead.
And that's regarding the website that Dr. Mehta was demonstrating. Oh, there she is. Okay, I'll wait.
Go ahead. No, after you.
Well, so my question was, so you've been building this. Oh, thank you. You've been building a network of value of the long hauler index. And so you're using that to help treat us as we receive our results. How will we be put in contact with those physicians after we go on the website? What do we do from there?
Yeah, so I think the whole key to this was getting live at a large laboratory that can accommodate, number one, all the testing that needs to be done. And then we can focus more on getting people into the treatment network. I mean, I think what was happening was InCellDX was doing both the kind of the running the assays and then interfacing with the long haulers, and then treating as many as we could, and we have treated a substantial number, like I said, with success. And so I think now the goal is, okay, we got a lab that can handle all that volume. And then once that's removed from us, then, because we had a similar kind of town hall with our physician network last week. So we're moving in that direction where we'll have a national network of physicians that we can do referrals and telemedicine and make our recommendations on treatment. And that's our ultimate goal. And like I said, groups like Dr. Galis's group in Florida, wanting to be involved and some of these other clinics, one in Georgia under Dr. Knopf, who was on our call. We even had Dr. Drew on our physicians, forum last week. So we will have a network, and I think once we can give hand the testing off, then it's all about the network and it's all about treatment. So, like Dr. Yo said, it's been we apologize for the delay, but we're putting all these pieces together. The great thing is they're all coming together. They're all going to be great. And, and I think we will then focus more on access to the therapies and access to treatment. That's what we all want.
Okay, so follow-up question. What do you think it's going to take to get our doctors to recognize the long hauler index as a basic standard of care and to follow through with the protocol recommended?
Well, here's the thing. The good news is we can show them data. I mean, we have the publications under review on the long hauler index and the severity index. So, as soon as that's published, we're sending them the preprint that's already out there. And we can actually show them data of people, and we'll get testimonials to go along with it with people who have improved and showed improved long hauler indices. I mean, it will probably require a small study with groups where, we treat, 20, 50 patients, in different centers and, follow their long hauler scores and show the relationship. And again, the app will help where we can show relationship to symptoms, lab values, and treatments. And that's really the goal of precision medicine. And we'll have that information. But for right now, the other thing I want to say to the long haulers is they don't have to wait for clinical trials for this experimental drug or that experimental drug, for long haulers. I mean, these are within the realm of immunology, rheumatology. The abnormalities that we see are not highly unusual. And now we know what drugs can normalize those cytokines and chemokines. So, it's called real world experience. I mean, if you go to a physician and they say you have a urinary tract infection, you think they go into some file cabinet and look up all the clinical trials on how to treat a urinary tract infection? No. Based on their experience, they give you drugs that have worked for them, right? And maybe that's a bad example because it's not the best treat. But the bottom line is you don't need a clinical trial to treat something that you know about that's within the realm of your training. And again, having the tools to do it and having the panels that we do. So not above and beyond the long hauler index, we can look at all the individual cytokines as well and say, wow, that's getting better. If VEGF is going down with Maraviroc, you should be having less peripheral neuropathy. Maybe your brain fog is getting better. So, we have that data, and that's what's going to be the hallmark of our physician network treatment.
And I just got on. Sorry, that was a fire alarm.
Thank you, Dr. Patterson.
That was a fire alarm in my place. I'll just jump real quick just to echo what Dr. Patterson said about the physician network. We've got doctors now set up in Washington, Oregon, California, Pennsylvania, Florida, and obviously New York, and that list is getting better. My phone is already blown up right now with doctors now reaching out to us just watching this feed. So it's a slow process, but we're slowly chipping away and getting there. There are a couple of questions on the forum about, and I know I think it might have been Lisa or Karen. You guys had some questions about some of the medications, a little bit more in depth about a lot of questions about Miravarak, leronlimab, Ivermectin, and whatnot. So, I think the first question, Dr. Patterson and our team get is, what is the drug? What is the thing that helps long haulers? Tell us that magic pill. I'll let Dr. Patterson tackle that question because we're getting that quite a bit. I don't know, Bruce, you want to take that?
Yeah, and I think the easy answer is, I don't think there's any one drug that will solve every problem. I think this is a multifactorial, immunologic disturbance. I think we've been seeing the best success with combinations, ivermectin, steroids, ivermectin, Miravarak, thymosin 1A. We saw some really impressive responses to that, and like I said, and we don't rule any drugs out. We let the great thing about what we do, because it's non-subjective, is if another physician has other ideas about therapies, great. But we have the immune panel to show that it's actually improving the underlying immune disturbances, and we're seeing a favorable improvement in the symptoms, and that's the way it is. But to say that there's going to be one drug that just cures everybody, I don't. That's not going to happen. But I do think we have a great set of combinations right now. I think that'll grow over time. Our toolbox of therapies will grow. Why? Because we have the data to support it, and that's what we're all about.
I think it's very important, Dr. Patterson, and the team is, we see a lot of information, and this is, I think the main thing is, I think we want everyone to realize is we are learning from the patients. We listen to the patients. I've talked to so many. I'm seeing everyone on this chat screen. I've obviously talked to Amy and Karen. And I know Dr. Patterson's his cell phone, his number is all over the place, and we're easily accessible 24/7. We're talking to doctors. We're having those conversations. I think the thing is, we're learning, and we know patients have told us, look, we've gotten ivermectin, and we want to know why. And now we understand why it's working and why it doesn't work for some patients. So we don't want to just throw something against the wall and cross our fingers and hope it sticks. I mean, ivermectin has been around for a long time. But now I think we're starting to get a better understanding of why. And by explaining why, now we get the buy-in from the medical community. Now we can have a conversation with another physician and say, why? It's an immunomodulator. It is affecting these cytokines, and here's the data. Another interesting drug we learned from the long haulers, thymosin alpha-1. I'm seeing this on the chat screen. We know a lot of patients have gotten that from their functional medicine or the integrative medicine doctors. How exactly is it working? There's some speculation out there. There's some literature. But now we're having a good idea, how does thymosin alpha-1 work? And we know which patients it is. So we can develop treatment algorithms that are going to be precision medicine, rather than saying, well, everyone gets ivermectin. Well, not necessarily, because there are going to be patients that don't respond to ivermectin. There are going to be patients that don't respond to steroids. There are going to be patients that don't respond to Miravarak/leronlimab. But we can identify who are those patients and give them that targeted therapy. And I think most importantly, by giving them treatment that is effective, then we can get them better sooner, rather than constantly throwing things up against the wall. And it can be such a frustrating process, which I know so many patients are going through that. Another interesting drug we're sort of looking at, I've been texting Dr. Patterson the last couple of days and pouring through the literature, is fluvoxamine. Luvox, use as an OCD drug. We're talking to our psychiatry friends. We're looking at this stuff. And now we're talking to so many other doctors and developing treatment plans. So it's not just a matter of just testing. And I always say there's a massive disconnect between the research world and the clinical world. Like, I'm a clinician. I'm in the hospital almost every day. And we don't hear about this research. Some of the stuff that Dr. Patterson was talking about before COVID, I had no idea. But, you know, because a lot of times we do this clinical research and it's great for the research community, but the clinicians don't hear it. The patients don't hear it. And so it's about creating this advocacy groups like you guys have, but also listening to you. A lot of you guys have connected us with those physicians. And that's why it's taken us quite a long time to really build this up. But you know, as Dr. Patterson said, we've got some success stories. We got patients that are feeling better. And we'll be reaching out to them to sort of come and talk about, you know, what is working and the approaches. And quite frankly, there has been some trial and error, and we're trying to figure that out. And I think we have a pretty good handle on what those therapies are. And that list continues getting bigger. I mean, if you asked us about a month ago about fluvoxamine, I think we would have just looked like, what is that? But now we have a good idea about that. We looked at niacin, antihistamines, low-dose naltrexone, where we have looked at that. They're not major needle movers. I think if they were, quite a lot of long haulers would have felt better, but they might be adjuvants. They might be something we add. Maybe it's a Moravirec. Exactly. Yeah, like a Moravirec and a niacin. But what exactly is that algorithm? I think we're starting to develop that and have that good understanding. And more importantly, it's getting that buy-in from the medical community. It's being able to scientifically speak to other physicians. And like I said, this is so much bigger than us, so much bigger. This is not a 2-3 doctor job. I mean, you guys are moderators and advocates in these big long hauler groups with thousands of people in there. It's humanly impossible for Dr. Patterson and I to be taking care of all these patients. So we're working on getting that buy-in and working on the network. And again, I'm always very grateful for everything the patients have taught me. Which sometimes it's a weird thing, in medicine where as doctors, we've gone through residency and training and taken all these exams and we're so all knowledgeable, but it's such a humbling thing to just learn from you guys. So just want to thank everyone for that. Now, who's not, I think is it Amy that had another set of questions? Okay, Amy, so we'll fire that up.
I do, but I'll be brief because you've touched on a number of these. We wanted to just touch on some of the medications that we're hearing about. Ivermectin mentioned constantly in my long haul COVID fighter groups, but I just would love to hear you say that it should be prescribed by a medical physician for human use, not ordered off the web for livestock.
Yeah, it should be prescribed by a physician for human use. I mean, the whole key is, as with any drug, is dosing and being confident that what you're taking is the dose that it's labeled with. And I think that's, no one's going to get better if they're getting something that's 10% ivermectin and 90%, beef gravy or whatever, So it's absolutely critical to have it prescribed by a physician and get it from a legitimate pharmacy. And again, some of the behaviors that we're seeing are not unlike what we saw in HIV, people going to Mexico and getting this drug or that drug. And it's just part and parcel to, the where you are in the disease process. If you don't really understand everything, people are going to try and do wild stuff. But as we get more and more confident in, the combinations that we're using, and we have data, which will have non-subjective data to prove it, I think we'll get away from some of that behavior.
I really hope so, because it keeps me up at night. It really does. We had to, put the kibosh on a lot of self-diagnosing and prescribing.
I think you bring up a very, very good point. And I think, sometimes we get so much into the weeds of the science and the research and obviously how the lab is working This is a public health crisis. It's a public health crisis, not only just what the long haulers are dealing, but the fact that our medical system is broken. Let's just get it out there that, first of all, patients don't have insurance. And I'm getting a lot of questions about how are they going to pay for this? And look, we'll take it on a case-by-case basis. We are sensitive about that. But definitely something we've talked about. But we'll take it on a case-by-case basis because we don't want this to be something that is only for super wealthy people. And we understand that there are minority communities, that are people that have lost their jobs, and we are sensitive about that. So even when we're trying to come up with the medication, some of them are expensive. Absolutely. People don't have insurance, but we're also developing treatments that are cheap, that are generic, Ivermectin, for example, and whatnot. Now, the other point, as Dr. Patterson touched upon, is the fact that patients are self-medicating themselves. They're going on WhatsApp, and some guy from India is prescribing Ivermectin to them. And here's the thing: I have a public health background. I have an MPH. I worked in the health department for years. From that perspective, I'm saying no, don't do that because it's bad. You don't know if this is legit. But from a human perspective, and not even as a physician, I understand why they're doing it. Their doctors have shut their doors on them. The medical community said, it's crazy. This is anxiety. You have PTSD. Something's wrong with you. You're a hypochondriac. And kick them out, literally kick people out of offices. I mean, how can I tell them don't do that when patients are telling me that's the only thing that's working is taking horse paste on Amazon? And that's when I told, Dr. Patterson, we had this discussion and we wanted to understand why it is working so that these patients can stop doing that. And here's the great thing. We got the buy-in. We got now doctors are prescribing Ivermectin for long haulers using our treatment. They are prescribing Miranda. Miranda has a black box warning for liver toxicity. And that's the first thing the doctors say. Well, here's the thing. We've tested about 30 patients with Miranda, and not a single one of them has elevated liver enzymes. Look, I'm a practicing clinician. I get it. I put medications in people every single day. I know how these things work. There are ways of administering medications. We should have to stop being technicians and start being clinicians. So, I know that Karen had a question about the IVIG and about, I'm trying to see what was the other thing you asked me about stem cells.
Stem cells.
Here's the thing. A lot of that we still haven't looked at all of them yet. I mean, as Dr. Patterson touched upon, there's still a box of medications that we need to look at.
Yeah, just a commentary on those two. I mean, number one, stem cells. I mean, how much is that going to cost? And like I said, the abnormalities aren't so abnormal that they demand something like that. And even IVIG, I love that. I mean, when I was at Stanford, I mean, we probably saved 2 or 3 people's lives who had, nasty respiratory viral infections with IVIG. And, and then it's also been used for, PANDA and some of these other autoimmune diseases. It's great because it inhibits the inhibitory antibodies, but it can also embellish the immune system. So it is a great approach. It's also, I think, $10,000 or $20,000 a pop. So if someone's in the ICU and we have to save their life, we're going to do that. But we're not going to do it for long haulers especially I think now that we've progressed as far as we have in terms of treatments that are working. So, but great thoughts. I mean, like I said, we're open to it. We're not shutting the door on anything because there's certainly been some surprises in terms of, mechanisms that are unusual. But, the further we get along and the further we define what's working and the correlates of success by using the appropriate precision medicine testing, we're going to be that much better off and patients are going to be safer. We're not going to do any harm trying to treat what they have. So
no one wants to get worse.
No, you don't want to get worse.
Thank you so much. I'm going to pass.
I want to just echo one more point. Oh, I'm just going to just echo one more point that Dr. Patterson mentioned about the cost. There are patients that are long haulers, and it just keeps me up at night. They've gotten pointless tests, MRIs, CAT scans, cardiac workups. There was a 43-year-old lady here where I live in New England. I've met her a couple of times, drawn her blood, worked with her on this stuff. She told me they've done they did a cardiac angiogram. They put her through stress tests. I mean, all sorts of things. And even before the results came, I said, they're going to be negative. I mean, how do I know? I do this thing for a living. I do cardiac respiratory work as an anesthesiologist. This is my daily job. And so we have, when we're talking about the cost, the tens of thousands of dollars that patients are spending, and then for the medical community to say everything is negative, go away. The other thing that concerns me is now we're slapping on these labels: chronic fatigue syndrome, fibromyalgia. Here's a secret. In medicine, when we call you a CFS or fibro patient, you're a crazy patient that we can't figure out what is going on, and we stop figuring out what's going on. How do I know? I work in that community. I do pain management. Anesthesia. This is a big part of it. But there's obviously a lot of research going into it. And I think what we're doing is going to add towards that. But going back to the cost thing, there's just a lot of pointless tests that are being done. And I know one long hauler, she spent close to $100,000 in testing. I mean, all sorts of scans and tests and everything's come back negative. So I think the approach from Dr. Patterson's research, and this is why I jumped on board, it made complete sense to me, is that the test, patients are getting blood work. Yeah, your CBC is going to be normal. Your chemistries are going to be normal. Your LFTs are going to be normal. And all your imaging studies are going to be normal. And then, yeah, everything's going to be normal. But we got to peel the layers off. We got to look a little bit more deeper. And I think with the InCellKind test, we've found something deeper. This is the first time. I would say a majority of the long haulers we tested, this was the first time someone said something is wrong with you. And the doctors we're talking to, we say 50% of the battle is acknowledging everything that you guys are going through. That's it. I mean,
it's huge. That recognition, that acknowledgement is everything. And we are so grateful that anybody's listening to us. It's the who's in Whoville. We are here. We need help.
Like Miranda said, I think we have to take it to another level too with the payers and all the administrators, so that they understand and these people can get taken care of and get the kind of disability coverage that they demand.
Yeah, and it's an uphill battle every day.
Yeah.
Every day we're hearing stories about, so we so appreciate your advocacy in the medical community side of things. And we certainly want to support your message and let people know that you're out there.
You know what? We'll turn the medical community around and get them on board, and then collectively we'll yield quite a lot of power in getting things done.
I know we got a couple more questions from the panel. I'll add one more thing. The network we are putting together, I can assure you guys and everyone that's watching it, these are the kindest, nicest group of physicians you guys will deal with. Something that, Chris and I and Dr. Patterson talk about is when we're putting this information out, whether it's on Twitter or on our website, is we're sensitive to that, the brain fog, the anxiety, just that almost that PTSD of like, are these doctors going to listen to us? Do we have to explain? And we are vetting every single physician. And when I'm referring and sending patients or talk to this doctor, the first thing I'm telling them, they're kind. You don't have to explain yourself. You don't have to tell them what long haulers are. And you're walking into that doctor's office knowing, and I'm putting my medical credibility on the line and telling everyone that these people are vetted. So we have not had a single, even if those doctors are still kind of like, and a lot of them are learning about long haulers and the science behind it and listening to our research and that buy-in from Dr. Patterson, the key is they're willing to work. I think that's all you guys want, just like work with us. And I think, I don't think any of us, I think any scientist, any doctor, none of us really claim like we have the answers. We don't speak in absolutes, but we are confident in our work and we're confident we're going to continue learning more. So I just want to throw that out there. is I've been connecting people with doctors and medical teams, and they're not just some random person that is just interested, because I know some of them are like snooping around because they just think it's kind of a cool topic. But these are people that actually have a vested interest, and more importantly, they are kind human beings, and they are good doctors out there. They're good medical teams out there. It's about a matter of finding them, and we are. So I just want to put that out there before we take a few more questions. So I don't know who.
Yeah, thank you so much for weeding out the gaslighters, because we don't need any more of those. So.
Absolutely. Okay, so who's got? I forgot. I lost track of who has questions next.
I think I'm up next.
Okay, go ahead, Lisa.
So back to Miranda and leronlimab. I'll ask the easiest question first. Are these medications, what form are they in? Pills or injections?
Yeah. The leronlimab is a sub-Q injection once every week, and Miranda is a pill twice a day. So it's been very easy to administer, especially on an outpatient basis.
Great. So what is the significance of a CCR5 blocker? And what are some of you talked about seeing like some great responses in some of the long haulers that you're treating. What are those responses looking like? Yeah. Are they like, is it curing all the symptoms, or is it just minimizing some of them?
Great question. CCR5 is a receptor expressed on immune cells, and RANTES is one of its ligands. So is CCL4 and CCL3. And it's basically they're chemokines, which are responsible for chemotaxis, which is basically moving immune cells around the body to where they're needed, right? Unfortunately, they go to some places where they're not needed, or could cause inflammation, like kidney, liver. I think some of the chest pain, this pericarditis that long haulers are feeling, I think is just inflammation of the pericardium, which is common in viral infections, actually. And the key to blocking them is twofold. I mean, number one, cross-linking CCR5 on macrophages prevents them from making interleukin-6, TNF alpha, and even VEGF. So one of the hallmarks we've seen in the Pfizer trials and the Cytidine trials using different CCR5 antagonists, it's very characteristic. The CD8 counts go up, interleukin-6 goes down, TNF alpha goes down, and now in the long haulers, we're seeing VEGF go down. What does that mean in terms of symptoms? Well, IL-6 causes muscle pain and joint pain. TNF alpha can actually cause depression. VEGF, as I said, causes this peripheral neuropathy, brain fog, and a burning sensation. Some people report under the chin, which I always find interesting. And all those go down on Miranda. So if I see someone who has a normal IL-6 and a normal RANTES or CCL5, I'm not going to put them on Miranda or leronlimab. But if I see that that's elevated, and I also see IL-6 is up, VEGF is up, I think those drugs are great for lowering those cytokines, which cause a significant number of symptoms. So I think that's why it is a good drug. The steroids are more general; they're going to lower kind of everything, in parallel. But in terms of targeted therapy, that's what I've been looking for with Miranda and leronlimab.
So it sounds like you've been repeating the long hauler index to kind of check levels again. How often are you doing that? And will that be something that those of us that participate in the long hauler clinic, will you check our long hauler indexes periodically?
Yeah, I mean, I think you have to do that because, like I said, we're looking for correlates of improvement. And when we start a therapy, we get a baseline. You take the therapy, and then we repeat. And that's what we've been doing with the patients that we've treated so far. and seeing the improvements, not only in the long hauler index, but we've also seen improvements in individual cytokines that aren't part of the long hauler index, like VEGF. I keep going back to that because I think that is a major player in long haulers, and it's elevated in 79%. And then I just got an email from our bioinformatics people that CD40 ligand is elevated in about 50%. And obviously that's got implications for platelet activation and coagulopathy and potentially, microemboli. So that's where we are right now, where I can actually sit here and tell you what's going on with therapy in terms of your immunology. And to be able to do that is just incredible. Do we have the full picture yet? No, it's going to take me a couple more weeks to do all that bioinformatics. But the bottom line is, we have a good handle on, when to use Maraviroc or leronlimab, when to not use it, when to use steroids, when to not use it. Ivermectin, I think, has been great because it's worked, I would say, Ram, correct me if I'm wrong, but maybe 85 to 90% of patients see a response in combinations with ivermectin. So that's what we're doing, and that's where we're headed.
Yeah, there have been some pretty incredible results with ivermectin. I know it's a controversial. I don't know why it's controversial. It's been used since, for the last 30 years all over the world. I think over like 2 or 3 billion people have gotten ivermectin. But there's been a lot of surprising, as Dr. Patterson touched upon earlier, definitely a lot of surprises. The ivermectin was definitely something we were interested in. And, now recently the thymosin alpha-1, it's like, okay, there's something interesting going on there. And us sitting on that data, which, over time, once we get it correlated in a scientific way, we'll definitely release that information. I think, again, end of the day, it's about making clinically actionable plans. I say that over and over again. It's great. You might have great research, but if you cannot make an actionable plan for it, it's useless in my books. And, that's just a really exciting thing, is we're taking all of this research and using it for practical clinical purposes every day. And we've got testimonials and stories coming out about this.
So with the Maraviroc and leronlimab, do you anticipate people having to take these just for a little while intermittently? Are you seeing people take them and get see improvements, but then once they stop taking them, symptoms return? So I guess my question is, are we looking at having to take these drugs lifelong, or is it just for a little while?
It's such a great question, Lisa. And I would say all the above except for the lifelong. We've seen people improve and stay improved. We've seen people improve and then get worse once they stop therapy. And I do think we're sort of narrowing in on this 2 to 4 week window of therapy and then off, which is good. I mean, that's a drug holiday anyway, which we used to use in HIV. But the bottom line, this is not lifelong therapy, and I think that's something that we can be optimistic about. But I think we're still trying to zero in on what the duration is. And the great thing is, it's the lab tests will tell us what the duration should be, right? That's why I keep talking about correlates of feeling better. We'll know when you feel better and your profile looks like this, that's where we want to be. And if the symptoms get worse, we retest, and it's not that, then we give the appropriate drugs to get back to there. And we may have to repeat that process, 1, 2, 3 times. But the bottom line is we could get somebody to feeling close to normal. And I think that's the whole key.
Well, that's promising that we're not looking at a lifelong term with these
Yeah.
drugs. My next question was just going to be about if you had patients that hadn't responded to these medications, but you kind of already touched on that, and sounds like it's just kind of everybody's response is individualized. So I will turn it over to Karen now.
So you briefly talked before about the struggles that long haulers are going through in terms of validation from their doctors, from the medical community, constantly being dismissed as having anxiety or depression or their symptoms being psychomatic. This is causing a lot of PTSD in long haulers. It's a lot of gaslighting. It makes us not have trust in our physicians in a time when we're going through so much, where we need their support and need their understanding, or at least their willingness to dive in and do the research with us. What are you able to do? I know you said you held a meeting last week with other physicians to discuss your findings and bring them on board. What can be done on a wider scale to get this information out there, that this is not psychosomatic, that we are not looking at anxiety? I know some of the lab results will obviously provide some data for this, but how can we reach more people via conferences or other webinars or something to really get this information out there versus just a handful of people?
Well, again, correct me if I'm wrong, Ron, but we had like 20 physicians on the call last week, and maybe 2 weeks from now it's 100. And then 2 weeks from then it'll be, 500. At some point, you're going to have a critical mass of physicians who are completely dialed into this. And the good thing, I mean, it's been in the Wall Street Journal. It's been in the national media. I've talked to the reporters at the Wall Street Journal about this. And, it's recognized. I don't think it's in the daily lexicon like vaccines are, but at least there's some discussion. And what we can do is just continue to build our physician network. Like I said, till we have 200, 300 physicians across the United States. Everyone's doing telemedicine anyway. So I think we can have access to far more patients because of telemedicine than we could in the past. And that's a good thing. And we'll continue to meet with them just like we're going to meet with, long hauler groups and long hauler, as individuals. So, and we'll be doing telemedicine as well. So I think that's what we're aiming for, is a grassroots, build it as a and get critical mass. And I think once we get critical mass, which I don't think is far away, I think we'll be in pretty good shape.
So let's say a long hauler goes to their doctor, either pre or post running the essay with you. How would you, advise them to advocate for themselves or push for more testing or not necessarily combat, but respond to a doctor who tries to tell them that this is psychosomatic, go home and shake it off?
Well, if they don't, then you go back to our website, and then you go through us to get a provider that will do this by telemedicine. I think that's the beauty of what we're trying to establish, is that you don't have to accept that anymore. We'll have providers. Ram's already said, we pretty much have most of the heavy populated states covered. And you'll go to one of those providers and have a telemedicine consultation and get what you need, because that's unacceptable. In fact, I think it's terrible. And if I was a patient and some physician did that to me, I would say, okay, I'm done here. You're not my physician anymore. Why do I have to take somebody who's not open-minded and not trying to figure out what I have, just denying that you have anything? It's awful. The reality is that's how I met my wife, is she wasn't sleeping, and for 2 weeks straight wasn't sleeping. And then came to me when I was at Northwestern, and I took her blood and figured out she had cytomegalovirus, which causes chronic fatigue. She had every doctor in the world wanting to put her into a psych hospital or give her psych drugs, because they thought she was just doctor shopping. And we figured out she actually had something. So I've been through that personally, and I think it's probably the worst possible feeling that a patient can have, is a doctor who won't listen to what they're experiencing or dismiss it. So.
Thank you. I think this kind of leads into some of the questions that Lisa had coming up, which is like, what would the long hauler index mean for long haulers in terms of those who had negative tests or those who were unable to get a test, who are still both fighting with physicians to get some type of treatment, or fighting with their employer, or even their own family members who don't necessarily believe them. Do you feel that eventually the long hauler index will lead to any type of official recognition, or at least medical coverage and qualification for short and long-term disability or Social Security disability? Is there anything in the works to have this officially recognized, at least similar to a PCR test or an antibody test or something like that, to prove somebody had COVID?
Right. I mean, again, I think we're still in the early stages of doing that. I would hope, like I said, I think one of the most important things was obviously getting this test validated at several nationally recognized CLIA laboratories, and so that physicians are less reluctant to send the samples for this kind of testing. Number two, keep publishing. Our AI publication will probably be out soon, and so that patients can go into their physician and say, here's 3 papers, that describe exactly what I'm experiencing, and approach it that way. And like I said, I think the rest will come. It just, like everything else, just takes time. But I think because we've already gone to payer groups and gotten CPT codes for the lab, I think there is, ability to get reimbursed for the testing. So.
And I guess the same question, it'd probably be the same answer, which would be for long haulers who want to take part in clinical trials and things like that, who they can't get into because they don't necessarily have any proof. If there are any studies going on with Miranda or leronlimab, which I know Dr. Galis is going to be doing a couple minutes away from me, some of them are asking for confirmation of positivity. Is there anything that can be worked around with that in terms of clinical trials?
Listen, if we do our job at the Chronic COVID Treatment Center and we're successfully treating all of you, why do you even have to do a clinical trial?
True.
To find out what we already know, that CCR5 inhibitors are going to have some benefit in some of the individuals. I mean, my rebuttal is I'll put you on Miranda tomorrow if your profile fits, right? So again, I don't, like I said in the beginning, this is not going to take experimental drugs. We don't have to wait till the IL-6 inhibitors get improved, and we don't have to wait till the neutralizing antibodies get improved, and we don't need to, it's just not that type of condition. So COVID was because it was an emerging infection and nobody had seen before, right? This is a post-infectious condition that is, like I said, we have fibromyalgia and post-Lyme registering on the long hauler index. So this is not something that demands enrollment in clinical trials necessarily.
Thank you so much.
And
I think
I was just going to add just one more thing. What Dr. Patterson said. You guys are not guinea pigs. We can't treat people like guinea pigs just because we want to. Well, guinea pigs in the sense, I mean, we are researching and looking at things, but I think with some of these experimental drugs and whatnot, and they have a lot of potential if they get approved. But we have to keep in mind our main purpose is really getting people better. Just get them better. That's the key. I mean, if that means we're not going to have a really cool research paper to throw in our CV, I don't really care about that. And I think I probably speak for the rest of our team about that. We're just in it to really help people get better, because I think all of us have been affected, even me personally, from COVID. I've lost friends of mine. I know long hauler friends of mine too, and I know Dr. Patterson the same way, and even with Chris, we've all been affected by this. So, I think the first thing is we're human beings. I think more than just doctors and researchers and scientists, we're coming at this as human beings. So I just want to throw that out there. And I think anyone that's talked to Dr. Patterson, Chris, all of us, just know we're regular people. We might talk about the science and whatnot. So I want to just always come back to the human element about why we're actually doing this. It's not because it's just really cool or fascinating, or we want to write a paper. We just want to get people better.
Yeah, absolutely. I second that. And the fact is, you should demand of doctors or even me, why are you giving me that? You won't get an answer from anybody else, but I'll tell you why. I'm going to give you something because I know I have data that shows that it does X, Y, and Z. And that's what we're trying to do here, is that I want to be able to give you reasons why I'm treating you the way that I'm treating you. Number one, I'm going to do the long hauler index is going to say you are a long hauler. But at the end of the day, I also want to be able to say, well, I gave you this drug because you had elevated TNF alpha, IL-2, and interferon gamma, right? And you should demand that of any physician. So that's just good medicine.
Or your VEGF and Ranties are ridiculous and
yeah. I give you this big horse pill so you can bring them down.
I have one quick question to interject. Have you ran the long hauler index on anybody whose numbers basically and everything have come back fine, but they're still experiencing long hauler symptoms? Have you run into that at all?
No, I've had, it was actually a really great anecdote to share, but I had, there was a woman and a son, and the son had really bad long hauler symptoms. The woman was kind of mild, and she barely made, she was like 1.1. I mean, she was barely above the cutoff, and her son was like 6. So that was really, for me, it was refreshing to see that here's somebody who barely had any long hauler symptoms and was a 1.1, and somebody who was worse off had a 6. So, again, we don't know if it's linear, based on index, like severity, it just goes up linear, or it's weekly, correlating with degree of symptoms. But we know in general, it comes down when you feel better, and and it's less when you have less symptoms. So
I know exactly who you're talking about. The inside scoop on that one.
Yeah, I think so.
Yeah. I think it's my turn. You guys are amazing. Thank you so much for hanging with us. We're way over the 2-hour mark here. So we'll try to keep moving forward. Initially, you wanted a handful of participants, and you got 200. And probably have, you've got a bunch of us submitting our info and ready to knock down your door to have access to some actual treatments that might hopefully help us improve. What are you going to do with all this data? Do you have plans for further publications?
Well, again, I think the most important thing, like Ram said, which was just key, I don't need any more scientific publications. That the academic side of my life is over, right? Well, not over, but I still ask questions. But I would say our science would be very much more directed towards contributing to management. Like I said, if you have these symptoms, the big question is, if you have these symptoms, what drugs do I have to use? And we're kind of going through that, we're answering that question kind of in a way where we're saying, okay, what symptoms are related to what abnormalities, what abnormalities respond to what drugs? And then by definition, we'll get to what drugs will treat these symptoms. That's really where we want to be. And that's really and I was struggling, should I keep, I'm really good at finding virus. I mean, that's how I cut my teeth on HIV, is I found it, and I found it in places where people weren't expecting. I'm good at that. But do I want to keep chasing that when I'm fairly convinced that it's persistent virus? Just because my academic mind wants me to pursue that? And the answer is no. I mean, I have a business. I have a responsibility to build what we have and help the most people as possible. And so I think our research is going to be very directed, like Ram said. It's going to be directed at you, the patients, and how can we make you better, and make you better in a way where you're not some guinea pig for different drugs.
And I will, just to that point too, no matter how many publications we put out, no matter how much we talk about it, there's still going to be naysayers. It's just part of being in the medical community. I think Dr. Patterson can probably, he's been doing this obviously much longer than me.
I've been doing it so long, I don't care.
Right.
Yay.
The word I always use is keep trucking along. We'll get people on Dr. Patterson's magic bus, and we're just going to keep moving. You're either on it or you're off. That's just it. That's just the way I look at it.
Yeah. Or as I like to say, you either get better or you don't. So
will you be applying for NIH funding or a piece of the big pie?
No. Why? I'm not in academia, so I'm not trying to fund myself or do anything like that. I mean, we have to charge a little for this test just because we have to manufacture it. But at the end of the day, we're not. My life of writing grants is over, thankfully.
Understood. And then you mentioned that you presented recently at a conference. Is that something you're going to keep doing, spreading the word? And
you should. I think it's posted somewhere, Ram, don't you? But you really need to see my Precision Medicine World Conference talk, where I hammered the lack of precision medicine in COVID, especially in long haulers. And I mean, this was a conference where, Fauci, there's 30 COVID experts. Fauci was there and others. And the fact is, that was the message. We need to use precision medicine in this very complicated disease. End of story, period. So yeah, I will continue to talk at conferences and at every opportunity.
Well, thank you very much for being an advocate and a partnership in this with us. So
yeah, I'm there for you.
We are very grateful. Any suggestions as far as helping physicians become long hauler literate, getting them the education that they're so seriously lacking, besides making them watch our webinar here?
I think Ram's got the right attitude. I mean, either you get on the bus or you don't. And if you don't, you're no longer going to have that patient, because that patient's going to come to our network and get treated appropriately and personally and nicely. And going to have a much better experience. So at some point they have to realize that, you know, that's their livelihood that's walking away because they're not open-minded.
Yeah, I have been advocating hard for a post-COVID clinic in my own healthcare network here in Portland, and I have been told pretty much point blank that it is not happening anytime soon. So I gotta go with who knows what's going on. So
Amy, you can probably talk to Dr. Yusuf, who I've connected you. I posted his information. He gave me the green light to post his information all over social media.
fantastic.
And Yusuf is working. I went to med school with him. He's and I think a couple of patients have already met him, and just wonderful things. And my friend over in Minnesota, Eni, one of my closest friends too. These are just good human beings and just great doctors too. And so if there are advocates and other long haulers that are interested in sort of setting up these clinics, and then, these guys are they have already bought into what we're doing, that, it's just it's a much more streamlined process too. And, the one thing I always tell everyone, I'm on the chat feed right now, tell your doctors, if they're interested, here's Dr. Patterson's number and his email and my email. I mean, today I was driving to the other side of town in a snowstorm, and I'm talking to the doctor with another long hauler, just kind of explaining things to them. And, and they completely agreed, and they were like, oh yeah, we're going to write for Ivermectin. We've never done it before. I'm like, go ahead, do it. But this is what we are there for, is we've got skin in the game now. This is not like us just going to telling the doctors, like, we're going to be able to do a consultation service now, where Dr. Patterson made and Dr. Parikh. We're going to come in and we're going to say, we're not just going to tell you to do this or this is what it is we've got skin in the game. We're going to give you an official medical consultation. There's liability associated. There's a lot of legal things. We're putting our medical licenses on the line now. And, I just want to address one thing is, we're getting a lot of questions about, well, what are the doses and how much to take it? And it's an ethical dilemma, because we do want to talk about this, but at the same time, I'm really concerned about people self-medicating. I'm really concerned about people getting ivermectin overseas and us giving a dose. I don't know what their it's just not good medical practice. So we're trying to work within the guidelines, within the system that we are in, and to do things in an ethical and sound way. And that means we link patients up with medical teams, and then we work with them. And I think, at least for me, that I go to bed, feeling much better that they're going to be in good hands and they're going to get the right medication from legitimate sources, not some guy from WhatsApp. I mean, that was just,
oh yeah, there's crazy stuff out there. It's
well,
dangerous.
I even contacted him because I was like, because I got that information. I was like, okay, let me see what this guy's all about. And he's like, yeah, PayPal me like $15 and I'm going to send you ivermectin from India. I go, who are you? Is it really ivermectin? Oh yeah, trust me, it's ivermectin. Okay.
It's chalk.
Right.
But who knows?
But it's embarrassing. We live in the United States, and many people are obviously in Europe that are following us too. We're living in these developed, highly sophisticated nations, and our citizens are resorting to animal paste from Amazon and some guy on WhatsApp selling ivermectin. I mean, that is, it's downright embarrassing.
I wholeheartedly agree. Yeah.
But here's the thing: we can sit there and focus on that, but it's not going to do anything. It's not, or saying, why is the system like that? We can complain about it, and we're about making actionable plans. And we want to put this positive message out there. We can sit and bitch and moan and complain and whatever. I don't care. I don't think Dr. Patterson cares. I don't think Chris cares. We're going to do our thing. And like I said, you're either with us or you're just not on the bus. So.
And we'll do it ourselves.
Good. I think we might be back to Lisa, and everybody is on the comments I'm seeing here really wants to make sure we get to talking about vaccines. So I'm just going to float that out there, and I'm not sure how much more time we have, but let's make sure we hit on that.
So I think that was Miranda's questions. Do you want to go, Miranda, or?
Yes. Thanks. Okay, thank you, Dr. Yo and Dr. Patterson. Okay, so these questions about vaccine. So many they're scared of getting a vaccine and fear that the strong immune response is going to continue and that it might do more harm than good in us. And then others report receiving the vaccine with no issues or minor issues. And then Dr. Redfield, the CDC director, stated that he would be afraid of the immune challenge caused in those still experiencing symptoms, aka long haulers. We share this theory, and we know many other long haulers do as well. So what is your take on long haulers taking the vaccine based on our symptoms and persistent inflammatory state? And does that recommendation change if we have antibodies or not? Because many still have them, many never developed them, like me. And those who don't have them have taken the T cell test that has been negative. And then there's still people who can't get their physicians to even order an antibody test, which is absurd.
It's crazy. I feel like you can walk down the corner and get one. It doesn't mean that it's good. But here's the thing.
So,
I agree.
Sorry.
I agree with the CDC director in this regard. And I think I put it out on Twitter, and people came back and said, well, I know people who got it and they felt better. Well, you know what? First of all, people who get the second shot feel horrible for good reason. Your immune system, when it sees something for the second time, is ready for it, and it's going to react heavily. And so that's my fear. Number one, if you're a long hauler, you've had COVID. So, in a way, everybody's going to be different. We don't know if you still have neutralizing antibodies. We don't know if you have cell-mediated antibodies. Cell-mediated immunity. You just don't know. But I would say adding fuel to the fire is a scary proposition. And my recent data with 25% of long haulers being Delta 32, I think if they were to get reinfected, wouldn't have severe disease. So, and I think if they got reinfected, even with whatever immunity still remains, they probably wouldn't have severe disease. So I'm just being cautious for right now. And I'm leaning towards not getting it. But I think it's a personal choice. I just think if you do get it, you better be prepared for a huge reaction. So those are my thoughts. I don't think there's certainly not enough information out there, and nothing's been published.
Thank you.
But I would agree with what he said.
Okay. Yeah.
Lisa, did you have a question?
Oh, I think we're at the end.
Say, Dr. Patterson.
You guys have to be exhausted.
Yes, absolutely. Brain.
Long night.
Thank you. You guys are amazing. Thank you so much.
Big scale. So,
it's like the most focus I've been able to have in a year, but it's important.
Oh, well, good. And listen, I so appreciate it. Everything you've said has been so helpful, and we're listening to, trust me, we're listening to every word you have to say. We're going to do whatever needs to be done. We're working as hard as we can. It may seem slow, but we're slowly building our network, and eventually we will get big and really big. And I think then we'll be able to have some say at the table with governments and things like that, so, payers. So
and I think as we continue doing this, we're going to be being advocates for the long hauler community. you guys, some of you guys have like become my friends. I mean, I've texted, called. I talk to you guys more than like my family and my friends. It's just, it's literally become a 24/7 job for me. I can't even begin to tell you. I've scaled my clinical practice by almost 80%, and I'm probably going full time into doing this for the next couple of months with Dr. Patterson. So, you know, like I said, this affected me because I've lost friends to COVID. I've actually got friends. We've tested my friends that are long haulers. So I have, you know, obviously a vested interest in this, in the subject matter. And I think, interestingly enough, you know, I think this opens the door for so many different, you know, we hear a lot of things about chronic fatigue, about, you know, there's another patient that reached out to us with post-West Nile virus. I mean, yeah, exactly. So I think this sort of approach, this precision medicine, really looking at the immunology on a much deeper level. And I know Dr. Patterson can talk about a little bit, you know, that even with active COVID, we don't know as clinicians where in the disease spectrum the patient is. Are they in the immunological phase, or what their levels of cytokines are? We're really going in blind. So I think this revolutionizes and changes the way we look at clinical medicine. It's really talked a lot about. We say precision medicine. Well, what does that really mean? I mean, what are the tests that we do? Do we run a different version of an EKG? Do we measure your heart rate variable? I mean, it doesn't really make, you know, it sounds really cool on paper. But to actually now have a plan, you know, we feel like this could get bigger than actually helping the long haulers, but also those chronic fatigue syndromes. Like I said, those patients that have been called crazy or put on all these medications and nothing's really been truly worked up. We can bust the door down and really understand what's going on. Those neuropathic pains, pain syndromes, cancer pain. I mean, so many different things. The potential is endless in what we can do. So I think it was important, you know, one of the things that, you know, putting this webinar together, I think the important thing was for us to now put a face on this. You know, Dr. Patterson's been in the background. I know I'm a little bit on social media, but, you know, it's taken us time to really build this and put all these arms together. And, you know, we worked with individual patients, but it's time consuming. But for us to come and present this stuff really took us several months. And we're just so grateful for the support and the patience you guys have had. I mean, our website is getting, I actually want to show this to everyone. This is our new redesigned website. I don't think anyone has seen this yet. So let me pull this up. I'm going to do my share screen. This is coming up in 2 weeks. One of the long haulers from California is building this. This is going to be our new website, and it's going to be obviously much more brighter colors and a little bit more functional. And what Chris and I joked, it's going to be a 2021 website rather than the 1980s website, which obviously didn't have the internet back then. But our point is, we're getting better. We're working to make this make this whole process streamlined and organized. And so thank you very much. And if there's anything we can do for your advocacy groups and your community, just call us, text us. We want to help. We'll talk to any doctor, any facility, any clinic. We'll brainstorm ideas with them, and we might get the door shut on us, and that's fine. That's what happens when you're a doctor and you're working in the medical profession. Doors get shut, but you just go open up a new one. So again, thank you very much for all of your patience and your support.
Yeah, absolutely. Be in touch.
It looks like Chris has something she wanted to add.
Yeah, let me add Chris back on real quick.
Hi, everybody. Thanks. Boy, this has been great. I've been really enjoying the discussion. I just wanted to make sure that when the new page comes up, which will be in about 3 weeks, as I may have not mentioned the last go around, the important thing is you do not need to re-register. It all goes into the same database. So those of you out there, I know there's a lot of you, I went into the comment section and recognize a lot of your names. So I just want to make sure do not go back and re-register. It's all in the, somebody has, we have a little dog that's even chiming in. This is great. So anyway, but I just wanted to make that point. Great discussion, everybody.
Yeah. Thank you.
Thanks so much, and we'll continue doing this more often. Thank you, Karen, Lisa, Amy, Miranda. Thank you very much. Thanks, Kristen.
Thank you so much for your time.
Thank you. Bye bye.
Good night.
Bye bye.
Bye.